Good evening, everyone. Most welcome to our webinar series on ultrasound guided knee pain management. We had already done 2 series previously, but that's been led by Dr. Das. And today we are honored to have another speaker, Dr. Igor from the Copenhagen. Just for the familiarity of the participants, I'll give the short intro of today's speaker. So Dr. Das is the founder of Daradia, the pain clinic, which got the award in excellence in pain practice as well. Dr. Das is the leading pain management doctor who has contributed significantly to the pain specialist. He wrote the book on clinical method in pain medicine that shaped the specialty of pain medicine and has more than 100 publications in peer-reviewed medical journals. He also taught pain medicine to 4,000 plus physicians online and offline platforms as of now. And he is the prime faculty at many universities and regularly delivers lectures in different countries. Dr. Das also been invited as a keynote speaker at many international conferences across different countries. And he is the ex-dean of the Indian Academy of Pain Medicine. So, sir, most welcome for today's webinar, and thank you to have you here.
Thank you, Geeta, for your kind introduction.
Thanks, sir. I'll also would like to introduce our second speaker of today's webinar, Dr. Igor, who has also joined. So thank you, Dr. Igor, for the joining. If I give the brief intro of the Dr. Igor. So Dr. Igor is a pain physician at Copenhagen Cryo Center and MD consultant anesthesiologist, which is highly recognized professional within the field of ultrasound guided cryoneurolysis. He is the founder and president of ISUGC as well. Dr. Igor has many years of experience performing his treatment in his clinic at Copenhagen, which established along with the Rene in 2014. Dr. Igor is one of the leading professionals in the world, which led a significant number of doctors seeking out his guidance in the hopes of expanding their knowledge with the field of cryoneurolysis. Dr. Igor has also published 1 article and reviewed 2 in the Journal of Medical Science. So thank you, Dr. Igor. Very warm welcome to have you here. And now I would like to hand over the dais to Dr. Gautam to take it over. Thank you.
Okay, so thank you, Dr. Geeta, and thank you, Dr. Igor, for joining us. We are very much happy, honored to get you in our platform. So the total areas of today's lecture and demonstrations will be divided in 2 parts. The first part will be taken by me. So where I'll be taking your ligaments. So there I'll be demonstrating in the 3D anatomy here first, all the ligaments. And after that, I'll be switching over to the another camera. And, I'll be demonstrating these ligaments, whatever I'll be talking here on MRT. And I'll be telling you the site, how ultrasound guided procedures, particularly in the ligament injury, the regenerative procedures can be done, the ligament, the needle pathway. So after I complete there, then Dr. Igor will be starting, and Dr. Igor will be talking mostly about the inner fascias and the cryoneurolysis. As you know, the cryoneurolysis is a very nice upcoming the areas, facilities, and just now we know that he is the president and founder member of this ultrasound guided cryoneurolysis society. So I'll be telling you, if you are also interested, you can join this society. I also have joined this society. So without any further delay, so first part, I'll be going ahead that I'll be showing this anatomy part, the ligament part. There are lots of things in the knee, normally we take 3 hours for this covering whole of the knee. So a lot of things, but today I will be focusing only on the ligaments. So if in the question answer sessions, if you wish to ask any questions, please restrict to your question to the ligaments and the inner fascias. They are the 2 important areas we'll be covering today. Ligaments by me and the inner fascias by Dr. Igor. So first part is your I'll be drawing some of the ligaments which is not there in the 3D anatomy. And already which is there, I'll be just marking it what ligaments it is. So one of the ligament is patellar ligament. Though you may not be calling it ligament, you may call it as a patellar tendon, which is not there. So as you know that patellar ligament is what? The quadriceps muscles are coming. And then after the patella, it is converted into patellar ligament tendon. Though it is not a true ligament in that way. So, but it is also named as the patellar ligament. So how to hold the probe? We'll be holding the probe here at the apex of the patella, and we'll be seeing that a very nice the hyperechoic fibrillar pattern of the patellar ligament or patellar tendon, and the cross sections short axis we'll be seeing that the toothbrush pieces like this, and below that we'll be seeing this the upper spine. So now coming to the other important ligaments, one very important is your patellar retinaculum, medial patellar retinaculum and lateral patellar retinaculum. So here it has shown the patellar retinaculum as a short band in this 3D anatomy, but actually it's much broad. So if we are drawing, so patellar retinaculum from here, it will be going, almost all around on the lateral and the medial side of the patellar retinaculum. That is the superficial layer of the ligaments. And it is a continuation of the vastus medialis and vastus lateralis muscles. So vastus medialis muscles on this side, vastus lateralis. So medial and the lateral patellar retinaculum, they are the continuation of that. After that, what is there in the second layer? In the second layer, so there are basically 2 or 3 layers. I'm just changing the color so that you understand the different layers. So below this, what is there is retinaculum. Patellar retinaculum. So it's almost the direction of these fibers are almost same. Means one superficial layer and just below the patellofemoral ligament. So medial patellofemoral ligament below the patellar retinaculum and lateral patellofemoral ligament on this side also. That is the second layer. Then comes the third layer. Third layer on the medial side is your medial collateral ligament. Let me take a different color. Medial collateral ligament. Medial collateral ligament again has 2 layers. One layer, superficial layer, is basically intermingles with the patellofemoral ligament, medial patellofemoral ligament. That means when you are sliding the probe on this side, so this side, after the patellar retinaculum, the next layer will be superficial band of the medial collateral ligament. And if you are sliding more closer to the patella, after the patellar retinaculum, we will be getting the medial patellofemoral ligament. And after the superficial layer, there is another layer which is meniscotibial and meniscofemoral. So that is the deeper layer. That means when we are holding the probe here, we are getting the 2 layers. Medial patellar retinaculum, and below that is your patellofemoral ligament. But when I'm holding the probe here, I'll be getting a third layer. What is the third layer? Is the deeper layer of the medial collateral ligament. That is your again having the 2 part, meniscotibial and meniscofemoral. Meniscotibial has another name, and it is also there on the either side, on the both the side. This is actually the meniscofemoral ligament. It is also known as the coronary ligament. So the deeper layer, also known as the deeper layer of the medial collateral ligament or lateral collateral ligament, the ligament, this is your known as the coronary ligament. It holds the meniscus firmly with the tibia. Otherwise, the meniscus might be stiff there. On the medial side, if you are coming, let me remove all these drawings. If I'm coming on the medial side, just quickly recapitulate. Vastus medialis now becoming continuous with the medial patellar retinaculum. Below that, we are having the either patellofemoral ligament, medial patellofemoral ligament, or that intermingles with the superficial layer of the medial collateral ligament. Below that, we are having the deeper layer of the medial collateral ligament, which is again having the 2 parts. One part is meniscofemoral, another part is meniscotibial. Meniscotibial has another name, that is your coronary ligament. Now come to the medial side. Medial side, vastus lateralis muscles is continuous with what? The lateral, the retinaculum. And now below that, again, lateral patellofemoral ligament. Again, lateral patellofemoral ligament is a little bit broader. And after that, there is again, this part is known as the meniscotibial, lateral meniscotibial or coronary ligament. If I'm coming little more laterally, then few other ligaments are important. One is what is not shown here. Let me draw this. That is known as anterolateral ligament. So anterolateral ligament is where? Anterolateral ligament is here. Just on the side of the Gautam tubercle. Here is another very important, the Gautam tubercle, iliotibial band. Iliotibial band, and just if you're sliding a little more laterally toward the posterior side, you'll be getting the anterolateral ligament. And after the anterolateral ligament, original insertion from tibia to the lateral condyle. The iliotibial band from Gautam tubercle of the tibia, it goes to the upwards towards the. And then if I'm going still more posterolaterally, then what we'll get? We'll get this ligament is your lateral collateral. Lateral collateral ligament is from fibular head, remember. It's not from the tibia. From the tibia to lateral condyle is your anterolateral ligament. And lateral collateral ligament is from fibular head to the condyle. And still, if I'm going more laterally, we'll be getting the arcuate ligament. Again, arcuate ligament is like V. It has two bands. One band is going straight, another band is going towards the meniscus. And they are basically the part of the capsule joint capsule. Okay, so these are the few ligaments. Transverse ligament basically that connects the two horn of the meniscus, lateral and the medial meniscus. It is joined by the transverse ligament. And this ACL just starts from below the transverse ligament. And that is the reason why when we hold the probe like this in the flexed knee, we try to find out the transverse ligament. And just below that anterocruciate ligament, we can easily find it out. And this is approximately depth of 1.5 to 2 centimeter. So that is also a very important landmark. Okay. Now, if I'm coming posteriorly, then again lots of ligaments, which is very important. One is your posterior cruciate ligament. Posterior cruciate ligament. So it's starting from the middle, almost middle of the tibia, and it goes to the medial condyle. And very important is, so this was your ACL, and this is your, so if you see the ACL from the below, it's going deeper, but here it is the ACL. And this is your PCL, posterior cruciate ligament. Posterior cruciate ligament is bounded by two horizontal bands. This is your from meniscus to the femoral. So meniscofemoral ligament. Meniscofemoral ligament again has two parts. This is your Humphreys part, and this is your Risberg part. So you see, these two ligaments are just like, the starting like this, the two finger, and in between it is enclosing the, suppose this is your posterior cruciate ligament. So it is like that. So PCL is like entrapped between these two meniscofemoral ligaments. So here, what is important? If I'm holding the probe horizontal a little bit of like this, what I'll see? I'll see this Humphreys and the Risberg part of this meniscotibial ligament, meniscofemoral ligament in long axis. And if I'm holding the probe like this, what I'll see? And the PCL is the short axis. So these two meniscofemoral ligament is the long axis and PCL is short axis. But if I'm holding like this, then what I'll see? I'll see PCL in the short long axis and these two ligaments in long axis. And after that, ACL is, this PCL in long axis, meniscofemoral posterior and the anterior band in the short axis, and also a little bit of ACL that is also in the short axis, small part of the ACL. And all of these things is covered by your oblique popliteal ligament. So all these areas is covered by the oblique popliteal ligament. Okay, so these are the ligaments what we'll be demonstrating today. And I'll be quickly, maybe in 1 minute, I'll be shifting to the another camera. But before that, if you are having any questions, any doubts regarding the attachment of the ligaments and how to hold the probe, you can ask me the questions before I'm switching to the volunteer. So lots of small, lots of large ligaments are there around the knee, and injury to those ligaments are always a possibility. MRI is the best, but still with the ultrasound also you can evaluate the integrity of these ligaments. Any questions by anybody? So, Seta team, can you allow them there to unmute and ask any questions regarding the 3D anatomy? Technical team of the GE.
Sir, they can raise the hand and then we can do it.
Okay, so ask them to raise the hand if anybody have any questions.
So there is a question in the chat box. Can we see all ligaments through USG?
Most of this ligament can be seen, not whole, like ACL, PCL part of PCL, most part of can be seen nicely. ACL part of can be seen, not all the things. But most of the other ligaments, at least part can be seen, but major part of this ligaments can be seen. I'll be showing you right now on the volunteer. Light scanning on the volunteer.
Sir, one more. Sir, excuse me. Can you repeat once again?
What? Which one?
Ligament parts. All the ligaments.
All the ligament again. We'll be
Again,
sharing the recorded videos.
Yes.
If you wish to ask me any particular ligament, one ligament, two ligament, it's fine.
Okay, sir. Okay.
I'll be showing you on
Shweta,
the volunteer.
Shweta, one request, if we can, unmute and take questions at the end, because Dr. Das will be take
So I'm asking because now I'll be switching because 3D anatomy I'll be switching. So I cannot come back to this.
Okay.
That is the reason
Fine.
I am asking anybody wish to see any particular ligaments. I can demonstrate it right now. Then I'll be shutting down this camera.
Okay, got it.
So there is one more question. Do you use hybrid technique?
Hybrid technique, ligament cannot be seen in with the CM. So hybrid technique means ultrasound and the CM both. So the ligaments can be procedures can be done based by the CM ultrasound guided. But sometimes it can take like ACL. You can inject into the ACL and you can see the whole of this ACL as the dye is how the dye is distributed. But most of the things, majority of the things can be done just by the ultrasound only. Okay, so what is hybrid technique? Hybrid technique means you are doing the interventions procedure both under the ultrasound guidance as well as the CM guidance. When we are taking this both together, then it is known as the hybrid technique.
Hello, sir.
Okay.
Just tell me lateral ligaments near the fibula and tibia fibula. Lateral ligaments.
Lateral ligaments. Okay. So laterally, what was the first layer I told? That is the lateral retiniculum. Okay, that is the continuation of the vastus lateralis.
Vastus lateral.
This is over this is your this ligament is your lateral patellofemoral ligament. Lateral patellofemoral ligament. Above that is your lateral patellar retiniculum. So lateral patellar retiniculum is a continuation of the vastus lateralis. Okay, so first layer was the lateral patellar retiniculum. Second layer is your this one, but this one is again a broad one. And here it is shown as a short band, but it is actually broader than this. Then this is another on the lateral side is your the meniscotibial, lateral meniscotibial ligament, or also known as the coronary ligament. Now, if you are going a little bit on this side, this one ligament is not there. That is your anterolateral ligament. Anterolateral ligament is like this. Anterolateral ligament is from here is your Gautam tubercle. So just lateral to the Gautam tubercle, here is your anterolateral ligament. And lateral collateral ligament is this. So lateral collateral ligament is from this is the fibular head. From fibular head to the lateral contact, this is your lateral collateral ligament. But anterolateral ligament is from the tibia to the lateral column. Okay, so still few more are there on the lateral side. This is our posterolateral side, I should say, or posteriorly, this is your arcuate ligament. So the lateral side, this is the ligament what we can see. Lateral patellar retiniculum, lateral patellofemoral ligament, the lateral meniscotibial ligament, anterolateral ligament, which was not here, and then lateral collateral ligament. And another thing I forgot to mention that is again is your iliotibial band. That is a broad band which is starting from here, the Gautam tubercle, and it is going along. Okay, clear? Little more complex is your posterior ligaments. The reason is posterior ligaments are little deeper. So I need to change the setup also, ultrasound machine setup when I'll be going to the posterior part. Anterior part and the medial and lateral part, your depth setting should be something around 3 centimeters. You'll be able to see the most of this part. But when you're going to the posterior part, you need to increase the depth up to the 5 centimeters. And that is the reason why the visibility might be a little bit problematic. So there is your posterior part. Posterior part, I told you, what are the ligaments will be seen? Posteriorly, first superficial layer will be the oblique popliteal ligament. Below that, we'll be seeing this PCL, and PCL is bounded by your wrist bulbs and the Humphreys part of this meniscus femoral ligament. It is bounded and closed by these two. And anterior to that, we'll be seeing the part of the ACL as well. Okay, so this much. Some part, the patient's knee should be, normally most of these procedures, patient's knee should be bent around 30 degree, 30 to 40 degree. And sometimes in some other situations, you'll be flexing it maximum as much as possible, like you'll be demonstrating the ACL. So initially, I'll be taking the preset MSK preset knee, but later on I'll be changing it to hip because it will be little deeper. So I have selected 20 megahertz probe, and my aspect marker. So this is the patient's right knee. Okay, two cameras are seen. So two different angles so that the probe is not obstructing your path. That is the reason why I have taken two cameras in the two different angles, but both of them are actually the right knee. So I'll be putting my aspect marker like this, and my lateral side will be the patient's, screen's left-hand side. That means left-hand side will be corresponding. Left-hand side, you can see the G mark is written there. So that is the aspect marker. So that will be corresponding to the lateral side of the patient. So here the patella, so apex of the patella, and if I'm holding the probe here, I'll be getting the long axis of the. Okay. So this was your apex of the patella was here, and this is your tibia, and this is your what? Patella ligament. This is your Hopper's pad. I'll be coming to this part little right now, the other ligaments. So this is your Hopper's pad, and this is your patella ligament in the long axis. There are certain situations which can happen in this. So there can be some bursitis here, bursitis here. But today we are just restricting ourselves over this patella ligament. Patella ligament in the long axis. And if I'm holding the probe here, you can see the patella ligament in the short axis. So nice toothbrush bristles like appearance. So this is your patella ligament short axis. Below that again, Hopper's pad. I'm just changing the camera. I have flexed it fully. I'll be showing you the anterior cruciate ligament. So anterior cruciate ligament starts from what I told below the transverse ligament. Transverse ligament is what? Transverse ligament is between the two horn of the meniscus, lateral in the medial of the meniscus, transverse ligament. It starts, actually just start and goes to the inner side of the lateral condyle. So this ligament has two bands, anteromedial and the posterolateral. Anteromedial band is thicker and posterolateral band is little shorter. So what I'm doing, I'm keeping my aspect marker towards the head side, cranial side, and distal side is your. So see here, never confuse this part as a cruciate ligament. I have seen many of our fellows make the confusion. So here the Hopper's pad has a very peculiar. This was your patellar ligament or tendon, just now I have told. But this part is your Hopper's pad. And this hyperechoic bright structure is in the cross section of the transverse ligament. So here, and this corresponds normally to approximately, so it is approximately 1.75 centimeter. You cannot see the centimeter marker here. I can see. So that is and this part, one part is hyperechoic, another part is hypoechoic. In some patients, some volunteers you'll be seeing both is little bit of hypoechoic also if the patient is not obesity, so that your penetration, as you know, hypoechoic means it is the anisotropy. Sometimes ligaments are seen hyperechoic or sometimes it is hypoechoic depending on the anisotropy. So both of them cannot be seen as a hyperechoic. Some part will be seeing hyperechoic, some part will be seeing hypoechoic. Like here, this ACL, this is the ACL, and this part is your hyperechoic, this part is your hypoechoic. So this is your anteromedial band and the posterolateral band. And if I'm just rotating the foot like this, the internal and the external rotation, you will see the orientation is little changed. So you see, first part is to identify this
at the depth of approximately 1.75 to 2 centimeter, you have to identify the transverse ligament. And you have to search the, see, this is your ACL. Very nicely seen this hyperechoic part, and below is a little bit of hypoechoic part. So you see, if the patient so if the patient is rotating it, you see the ACL orientation is changing. So now you are see, so you see when he was doing like this, and you see that this was the patient, the anteromedial band is listing little bit. And now you see the posterolateral band also, below part is your posterolateral band. Now the posterolateral band is nicely seen. Okay, fine. So this was the ACL. And as I told you, this also looks like ligaments. Never make any mistake. So how to avoid this mistake? At around 1.5 to 2 centimeter, try to search the hyperechoic, the transverse ligament, and you search it below that. So if you wish to, somebody was talking about the hybrid technique. So what you can do is, under this ultrasound guidance, your needle should come like this, and you can give the regeneration therapy, PRP injection, or whatever it is. But also what you can do is, you can give some dye, and you'll be seeing the dye both in the lateral view as well as in the AP view. And you can identify the ACL also till the attachment, where it is getting attached. Here, I cannot see the attachment here. When I'll be looking at the posterior part, I'll be seeing a small little part of the ACL. But here, ACL is very nicely seen, but only the part of it. And in the short axis also, I can see the ACL. And I can see if I'm holding the probe like this, I'll be seeing the transverse ligament in the long axis and ACL, small part of the ACL like this. So you see, if I'm holding the probe like this, so again at around, so some part is hyperechoic, some part is hypoechoic. Okay, so at the around depth, so this is the depth of around 1.52 centimeters, I told you. It is exactly 1.75 centimeter. So this is your transverse ligament. And below that, there are two parts basically. So this part is looking hypoechoic, this part is looking hyperechoic. So this is your anteromedial part, this is the posterolateral part. But if I'm doing the internal rotation, external rotation, you'll see the echogenicity will be changing. I'll be just showing you dynamically. I'll be just internally, externally rotating the foot, and you will be seeing that the echogenicity of this ACL is changing. So again, I'm unfusing it, and so you can see this was the transverse ligament, and just below that, so that is a small tiny part of the. So this is the origin part. So this was now showing the hyperechoic, and hypoechoic part is seen as a hyperechoic, part is seen as a hypoechoic. So this is your transverse ligament, and this was your ACL, small part of the ACL at its origin. And what other things I can see here? So this was the patellar ligament or tendon, and this was your Hoffa's pad. Okay, so this was a little bit about the ACL. Now I'll be going Now I'll be going to the medial side, the ligaments, and then I'll be going to the lateral sides, the ligaments, and then posterior side. So here when I'm seeing the medial side, I'll be camera down focus. So I'll be making little bit of externally rotated, slightly externally rotated around 5-10 degree, and you'll be able to see it better. Here there is some depression, so you have to put lots of gel in. So now my aspect marker is towards the anterior side, and that means anterior side is your. So anterior side, let me reduce the depth a little bit more so that you can see is even better. Okay, so first let me show you what I can see in this picture, and then I'll be going. So you see, this was your anterior side. So this is the patella, and below that, this is the articular cartilage below the patella on the medial side. This was your medial condyle, and this was the articular cartilage of this medial condyle. this is some pads. And you can clearly see the two ligaments very nicely seen. One part is your this part. This was your patellar, medial patellar reticulum. Another was this part. This was your patellofemoral ligament. Okay, just look very nicely seen. You'll not be able to see, this kind of, but here I'm using 20 megahertz probe, that's why I can see these ligaments very nicely. So the superficial layer is your medial patellar reticulum. So now you see what I was telling, medial patellar reticulum is a continuation of the vastus medialis. You see, if I'm going above, what is happening? You see, I'm going above. Can you appreciate the vastus medialis muscle? So this was vastus medialis muscle. See how I'm holding the probe. Now I'm coming down, and now that is, see, that was the vastus medialis, and now that is converted into the medial patellar reticulum. So this is the medial patellar reticulum, and below that is your patellofemoral ligament. And these ligaments are not tiny, quite big. You see, this was your continuation of the patellar reticulum, and below is your patellofemoral ligament. This side was the patella, and this black is your hyaline cartilage, because here what I'm doing, I'm seeing the undersurface of the patella. So this is the bone, this is the undersurface of the patella, and this is your articular cartilage. Because here I am seeing the below, from this side, I am seeing the undersurface of the patella. And here intra-articular injection through the medial patellar reticulum is done in this way. This way, you can come and you can give the intra-articular injection there. But anyway, today I'm restricting ourselves into the, so here you can see the very nicely seen two bands. Above one is your patellar reticulum and below is your patellofemoral. So now, if I'm going more medially, and now what I'm doing, so what will happen? Patellar reticulum will be patellar reticulum, and the deeper layer, that was your second layer, was you can see very nicely the second layer, that is patellofemoral ligament, that will be continuous with the what? With the superficial layer of the medial collateral ligament. So you see here, if I'm holding up, my aspect marker is now, I am in the long axis, my aspect marker is towards the cranial side. And you see here very nicely two part is seen, even the three part is seen. So if I'm going above, so this is also your vastus medialis muscle in the long axis. And you see this is the continuation of this above layer. This is the medial patellar reticulum. And below that is your superficial layer of the, so if I'm holding the probe here, you can see all the layer very nicely. I'm teasing it and I'm drawing it. So what you can see here, the above layer, this layer is your medial patellar reticulum. Below this layer was your what? Superficial layer of the medial collateral ligament. And this part, this is little tiny in the long axis in that way. So that is your menisco. So this is meniscus. So meniscus. So meniscofemoral, and this is your meniscotibial. Meniscotibial or coronary ligament. This part is your very nicely seen coronary ligament. Above that is the superficial layer, and then your patellar reticulum. And this superficial layer and the patellar reticulum will be continuous. Little down also, if I'm tracing, it will be continuous. You see, I was here, I was seeing all three parts here. In patellar reticulum, then your superficial layer of the medial collateral ligament, then your coronary ligament or the meniscotibial part. If I'm coming down here, you can see again the two layers very nicely, one layer, another layer, and you can see something pulsating here. That is that lies below the superficial layer of the medial collateral ligament is your inferior medial genicular artery. So it accompanies the nerve also. Nerve can be proximal or distal to it. So in fact, nerve is also seen nicely, just adjacent to it. And if I'm still coming below, we can see the pes and serum tendon there. Three tendons together. Pes and serum, you see now it is better seen even. So the pes and serum tendon you can see, and this ligament runs like this. So here it is getting attached. Superficial layer of the medial collateral ligament. So here, just quickly recapitulate, medial side. If I'm holding the probe in this way, I was seeing the two layers. One layer is your very nicely seen now. One layer is the medial patellar reticulum, and below that medial patellar reticulum, and below that patellofemoral ligament. If I'm coming more towards this and in the long axis, So vastus medialis muscle is continuous with the you can see the two layers, one and another here. And if I'm coming, that is your medial patellar reticulum, and this is your the patellofemoral ligament intermingled with the superficial layer of the medial collateral ligament. And if I'm coming here, I can see the around the meniscus, I can see the third layer also, meniscotibial and the meniscofemoral. And if I'm going down, I can see the patellar retinaculum, and these things is going down and getting attached to the tibia. And below that, I can see the genicular, inferior medial genicular artery also. So this was the medial side. Now come to the lateral side. Lateral side is almost similar. So here, but some other additional things are also here. So here also you'll be seeing the same patellofemoral ligament and the lateral patellar retinaculum and lateral patellofemoral ligament. Here I'm putting my aspect plantar posteriorly. Okay. So almost similar. So this was your patella. This was your the articular cartilage of the patella. This was your condyle. And here also you can see the very nice. This was your patellar retinaculum, and this is your patellofemoral ligament. And as I told you, patellar two layers that is very distinctly seen, very nicely seen. So if I'm sliding my probe above, I'll be seeing here, see sliding the probe above, superficial layer is basically continuation of the, you see, the vastus lateralis. So this is the vastus lateralis muscle that is becoming continuous with the superficial layer. So the two layers here I can see, and here also I'll be seeing another part is your lateral coronary ligament or meniscus. So this is the meniscus. So this part will be the meniscotibial, lateral meniscotibial now of the ligament. Now, if I'm holding the long axis, I'll be seeing a lot of things here. First part is I'll putting one is the guardis tubercle, palpate the guardis tubercle here, and the fibular head here. So the two important landmark here from which the lots of things are originating. From the guardis tubercle, what will be originating? Iliotibial band. See, this is the iliotibial band. So this is your guardis tubercle. This is your lateral condyle. Here it is the tendinous origin of the popliteus muscle. Here it is the lateral meniscus. So this is your what? Iliotibial band. Iliotibial band looks like this. Hypoechoic, little bit of hypoechoic, and it's very small. The fibers of the fibular things, you'll be able to see it. So this was your iliotibial band. You see again. So tibia, guardis tubercle of the tibia, and it is going above. Now here, if I'm going sliding little down, so iliotibial band is vanished. In fact, below the iliotibial band also, this hyperechoic structure is your anterolateral ligament. Anterolateral ligament is quite thick. It starts below the iliotibial band and little bit of even the lateral side of the guardis tubercle. This part is all your anterolateral ligament. So that is the anterolateral ligament. That lies below what? Below the other two layers. So if I'm holding it horizontally, so you can see, in fact, the patellofemoral ligament intermingles with the anterolateral ligament. Okay. Now, if I'm sliding my distal end towards the fibular head, so here was your fibular head. If I'm sliding my probe here, so this is the fibular head. I'm freezing here. So this was your fibular head. This is your tibia, meniscus. Meniscus is anisotrophic now. This is your lateral condyle. And now the ligament, what you can see is the lateral collateral ligament. So lateral collateral ligament do not attach with the tibia. It is attached with the femoral head. Whereas anterolateral ligament attached with the tibia. Just guardis tubercle and the adjacent areas on the lateral side of the tibia. So if I'm sliding my probe little more medially, I'll be seeing the anterolateral ligament, little over the fibula, then I'll be seeing the lateral collateral ligament. Now I'll be making my volunteer prone. First, this is the other leg. This is the left leg. Because it will be closer to me, it will be easier for me to demonstrate. So what I'll show, first I'll be in this setup, I'll be showing you the almost look same, but I'm holding the probe posteriorly. And I'll be seeing the arcuate ligament. So I'm unfreezing. And after that, I'll be changing the setup to see the PCL. Okay. So my aspect marker is cranially. And I am just searching the fibular head. So I'm palpating the fibular head. Bony landmark can be palpated and then seen. So this is your let me increase the depth a little bit. Okay, so here it is. You see, it's almost looks same like that of the lateral collateral ligament, but so here what I can see, this was your fibular head. This was your fibular head. This was your tibia, and this is your condyle. And from the fibular head, this area is your arcuate ligament. It is a lateral part. If I'm holding the fixing it over the fibular head, and if I'm turning the probe little more medially, that will be the meniscal part of the medial band I'll be seeing. So you just look here, and I'll be unfreezing. Okay, so I was here, and this part is your condyle, and this is your articular cartilage. Articular cartilage looks black. So this is your condylar cartilage, and we can see the arcuate ligament here. Arcuate ligament basically intermingles with the joint capsule. Now what I'm doing, I'm tilting my proximal part more medially. So this part here, now this part, which is getting attached to the meniscus part, that is another part, medial band of the arcuate ligament. So arcuate ligament is visible. One is like this, another is like this. Okay, now I'll be changing the setup. I'll be going deeper. I'll be taking the hip setup. Big high penetration. So as you can remember, what I told, the PCL is attached in between the, in the middle of the tibia and gets to go towards the medial condyle, medial side of the inner side of the medial condyle. So what I'll do, this is very easy way to find it out. Initially, I'm holding the probe here. So what I can see, this is your medial condyle. This is the articular cartilage. Above that is your semitendinosus muscle. And this is your little bit of tibia seen. This is your meniscus. So from here, I am focusing over the tibia, and now I am sliding my probe more towards medially. And now this is the very important home page for me. So I'll be demonstrating it. I'll be telling you what exactly I can see here. Okay. So here, after this muscle, gastrocnemius muscle, this is a very bright white band that is your oblique popliteal ligament. Oblique popliteal ligament. This is the wristbar part of the meniscofemoral. Meniscofemoral ligament is what? From the meniscus, it goes to the medial, condyle of this. It's like that. And this is the wristbar parts. And this hypoechoic part, little bit of hypo, little bit of hyper. This is your long axis of the posterior cruciate ligament. So it is bounded by two parts of the meniscofemoral ligament. This is anterior part, and this is your posterior part. This is your PCL. This is your oblique popliteal ligament, OPL. Okay. Now again see. So I am starting from here. I am focusing over the medial condyle and the tibia. So when I can see the two bony prominence, I am sliding. Once I am getting this image, I am tilting the proximal part little towards the condyle, little, not much. Then I can see the PCL very nicely. And you can do the heel toe maneuver so that you can see it even better. So now the PCL is very nicely seen. So this part is your PCL. Okay, so this is the long axis and short axis. What I should do? The short axis, I'm keeping my aspect marker the lateral. That means left hand side of my screen is your laterals. So here, what I'm doing, I am first putting it into the intercondylar area. So on the left hand side, this is your lateral condyle. This is your medial condyle. You can see the articular cartilage of the condyles. And now what I'm doing, I'm fixing the medial condyle, means the other side I'm fixing. Right hand side I'm fixing. And left hand side I'm going towards the meniscus. Means I'm over the condyle. And now I'm going towards the meniscus. So what I can see here, this was the oblique popliteal ligament. And below that, this hyperechoic line is your posterior band of the meniscofemoral ligament in the long axis. And this is your anterior band. And in between, the cross section of the PCL. So this is your PCL. This is your anterior band of meniscofemoral ligament. Sorry, posterior band of the meniscofemoral ligament. This is anterior side. So this is anterior band of the meniscofemoral ligament. And this is oblique popliteal ligament. And here you can see a part of the ACL, posterior part of the ACL. Okay, so I am again increasing the gain a little bit so that you can appreciate it a little better. Okay, again, see what I was first holding the probe between the two condyle. So this is the two condyle, medial and the lateral condyle. And always put a lot of gel. Aspect marker is towards the lateral side. That means left hand side is the lateral side. So you can see the two condyle, lateral, medial condyle. Once you are getting it, fix the medial condyle. Right hand side is the medial condyle. And then I'm sliding the probe towards the meniscus. This is tibial bone. So just above the tibial bone here. Okay. So this was your, again, I'm drawing. Now it is much better visible because I have increased the gain a little bit. So this was your oblique popliteal ligament. This was your posterior band of the meniscofemoral ligament, looking hyperechoic. This is your cross section of the PCL. This is your anterior band of the meniscofemoral ligament, and this is your ACL. So the small part in the cross sections I can see of the ACL also. So this is your posterior side, and here you can see my depth is the 5 centimeter depth, and I have used the high penetration. So this is your PCL. Okay, so this much from my side. Any questions I can take, or I can take the questions later on. But if somebody, because I will be putting up the cameras, so if somebody wishes to see any questions quickly, I can, any part again quickly, I can demonstrate quickly. I'll not take, because I have already taken a lot of time. I'll not take much time. So if anybody wishes to see any structure again quickly. Okay, Geeta or other team are there. Otherwise, let us, hand over the mic to Dr. Igor because he's waiting. Anybody from the tech team?
Yes, sir.
Okay, you can I take question answer 1 or 2 questions right now or after the Igor's lecture?
Sir, as you wish. We can
Sir,
do both.
sir, may I? That will be better. Let Dr. Igor continue.
Okay,
Then
yes,
we
yes.
can
Dr.
take
Igor is
questions
waiting
and-
long time. So
Correct.
my volunteers and me are here. So let Dr. Igor complete it and then again I can come back. Okay? With questions. I'm stopping sharing.
Thank you. Can you see my screen now or?
Yes, we can see your screen.
Yes. I will talk about principle of cryoneurolysis and ultrasound guided cryoneurolysis for treating the knee pain. This will be like prolongation of Dr. Das's presentation, which was very helpful and very nice, and he showed us actually how and complicated joint is a knee joint. Disclosures, I have nothing to disclose. What is cryoneurolysis? Cryoneurolysis is a specialized interventional technique which provides long-term pain relief. We use low temperature to ablate the peripheral nerves. We provoke the process called Valerian degeneration, but we remain endoepi and perineurium intact, which allows the axons to regrow with 1 to 2 millimeters per day. The duration of the effect is highly variable. We have patients from follow-up 5-6 years who are pain-free. We have some patients where there's no result. In the approximately, I would like to say between 9 and 10 months, it's the effect of cryo. It's a variable sensory and motor block depending which nerves we are going to treat. What is the physics behind cryoneurolysis? You can see this is the cryo probe, and you can see that the gas is, we are using CO2 or nitrous for freezing. You can see here that the gas is coming from the outer part of the needle, and then there is a small pipe inside which is taking the gas out of the needle. We have a small narrowing here, which is increasing the velocity of the gas, which is known as Joule-Thomson's effect in the physics. And this allows the temperature to fall down and to be produced an ice ball in the needle tip. And the point is that the nerve should be inside this needle tip, this ice ball. These are the several devices which we are using for cryoneurolysis. You can see from handheld to devices which are using gas like argon and helium, and which are very powerful. The others are gases which are for CO2 and nitrous. What type of gases we are using for cryoneurolysis? We are using carbon dioxide, we are using nitrous, and we are using argon. You can see the different temperatures which are for the specific gases or boiling temperature. Shapes of the probe and the ice ball formation. We have two different types of probes. We are using a blunt one, and we use the triangular shape. The blunt one, you can see they produce very nice oval shaped ice ball, which is about 1.5 centimeter long and 1 centimeter thick. And then we have the triangular shapes, which are more oval shaped. So is there any difference in the between the ice ball and the temperature? I've said no. The larger probe size, they produce larger ice ball, but we don't know if the temperature is colder. Shape of the probe doesn't have any influence of the effect of the result of the cryo. Warmer body temperature increased cryo probe temperature potential. The ice ball size is not always correlated with the temperature. We can see that the ice ball, carbon dioxide produces 40% bigger ice balls, but they're 9% warmer compared to nitrous. So ice ball with the same size did not always have same core temperature. So this is why it's very important the middle tip to be cold, not how big the ice ball is. This is where the focus should be. According to the histology, we know that there is a five categories of nerve damage. The first one is neuropraxia, and this is the nerve damage with minimal histological changes. The second degree is axonotmesis. This is where the nerve damage is coming with the loss of axonal continuity. And this is where we aim actually with cryoneurolysis. This is where you can treat the nerve with temperature between -20 and -88, which is the safe window where you can actually provoke the Valerian regeneration, but still the nerve is not, you're not going up to the third, fourth, and fifth degree of the neural damage, which are the complete destroying of the nerve. I always say you cannot treat what you cannot diagnose. It's very important before we get actually patients for cryoneurolysis, and before to attempt doing the freezing the nerves, we have to do the diagnostic block. Diagnostic block is we're using diagnostic blocks with 0.5 to 1 milliliter of lidocaine. All procedures should be ultrasound guided, and we are using also neurostimulation together with the ultrasound. And there's two things. One thing is to confirm that the problem is isolated from a sensory nerve. And the other thing is to be sure that we are not touching the motor nerve, because if we are freezing the motor nerve, so the nerve will be inactive for up to 3 months. For pain treatment, we solely treat sensory nerves. When we are doing spasticity patients, we are treating the motor nerves. So this is where we use actually the two different types of nerves. But for the pain, we are freezing sensory nerves and also the mixed nerves, like suprascapular nerve, for example, for shoulder pain. What are the advantages of cryo comparing to radio frequency? There is no neuroma formation. Cryo can be used on the large myelinated nerves, can be repeated, the nerve growth back. This office procedure, and we are beginning to use more and more cryo for preoperative pain treatment. And this is because the cryo is offering actually a very nice opportunity for painless rehabilitation in the first 4 months after, for example, total knee replacement or shoulder replacement, so the patients can start with the physiotherapy immediately. What are the complications? There is no written report of permanent nerve damage. We can provoke skin discoloration if we are freezing if we do some frostbites. Alopecia, when we treat the headaches, so the small part of the hair can fill up. Thrombosis, infection, and bleeding. There is only one paper describing the thrombosis of arteria dorsalis pedis when they try to freeze the deep peroneal nerve from the foot. But this is only one, and it happens in 1969, where the temperature fell down to minus 190 degrees. But because now we are freezing up to minus 40, 45 degrees, so this is the safe window where we cannot actually freeze the arteries. What are the contraindications? The majority of these are relative contraindications. The only absolute contraindication is paroxysmal cold hemoglobinuria, but it's only 1% of the world population having this issue, so everybody is issued with a special card so they can tell to the doctor. What are the possible side effects? We experienced that 1 to 3% of our patients are experiencing severe dysesthesia in the area of the treatment or in some part of the dermatoma which was treated, and this is interfered with sleep and daily activities. Some of the patients repeat the increase of neuropathic pain, and now we are talking about trying to find out why is this happening. There is two possible explanations. The one explanation is that we haven't frozen the nerve, the whole circumference of the nerve. So one part of the axons are still alive, we can see, and then the pain actually is much more, it's much higher than it was before. The other thing is we have some evidence that if we are freezing the nerve with surgical exploration, And as more as we touch the nerve, the risk of complications or side effect after the treatment is bigger. So that's why we actually promote that the cryo should be percutaneous procedure, and then as less possible touching the nerve. So it means that, and try to freeze the nerve of the both sides, above and under the nerve. We are working a lot to implement cryo in the acute pain management. This is not going very well because there's different things why it's not affected so much. But we could see that in different procedures like mastectomy, thoracotomy, total knee arthroplasty, burns, give grafting, rib fractures, amputations, and shoulder injuries like rotator cuff syndrome and at young patients could actually be used cryo preoperatively. With shoulder injuries for rotator cuff, we can see that 60% of the patients, if we use cryo to treat the pain, they can actually avoid the operation. They can avoid the surgery. We can treat them only with physiotherapy and pain treatment. What are the indications for chronic pain? I usually say everywhere on the body where you can find the sensory nerve. So it's from head, neck pain, shoulder, elbow, hand, intercostal, the whole trunk pathology, cancer pain, foot ankle pain, peripheral neuropathies, diabetic neuropathy, chemotherapy-induced neuropathy, low back pain, sacral and joint pain. So everywhere where you can find the sensory nerves. I would like to talk shortly about the knee treatment, how I perform the knee treatment and what I recommend for treatment for the knee pain. We know that knee osteoarthritis, it's about 4/5 of the burden of osteoarthritis in the whole world, and it increases with obesity and the age. This study shows that global prevalence of the knee was 60% in individuals 15 years old and higher, and then 22.9 in individuals more than 40 years. And then we can see that the global incidence of the knee osteoarthritis was 203 per 10,000 persons, so which are 20 years and old. So we see actually that the number of patients with knee problems is increasing worldwide. It's not only in several countries in the whole world is the problem. Here you can see the same study, where we can see the increases, the prevalence is increasing with the age. And also we can see that the women actually are getting more pain treatment compared to the men. There is a lot of talk about the nerves innervating the knee joint. It's very complicated, it's very complex joint. And we're talking a lot about genicular nerves. I say that all the nerves coming from the femoral nerve and down to the knee are called known as a genicular nerves. You can see here the supromedial nerves. There's the nerve to vastus medialis, vastus intermedius, medial branch. So this is where of the anterofemoral cutaneal nerve. And I suggest always we should use the precise names of the nerves which we are treated. Otherwise, we're mixing some anatomical things together. What I usually do for my patients is I treat infrapatellar branch of the saphenous nerve, and then I treat the anterior femoral cutaneal nerve for the knee pain. Here I would like to show you there is two ways how to trace the nerves, infrapatellar branch of the saphenous nerve. And you can see this picture here is the picture from sartorius muscle. We have femoral artery. This is a ductor channel down. We have the saphenous nerve here. And you can see it's very important that we are starting to trace the sartorius muscle. And we are tracing the sartorius muscle down to the knee, where the point you can see the sartorius muscle is becoming smaller. Here on the left side, you can see there's some nerves showing slightly. Here some small dots are coming. This is where I have to focus. There's 4 different ways how the infrapatellar branch of the saphenous nerve is penetrating the sartorius muscle. One is above the nerve, one is on the back side of the nerve, one is below, and one is through the nerve, through the muscle. So here you can see now it's very small, the sartorius muscle, and you can see here on the left side, we can see the infrapatellar branch of the saphenous nerve. On this video, now you can see here I'm tracing, but here suddenly those two dots are the infrapatellar branch of the saphenous nerve. You have the patella there, and we cannot see the inferior genicular artery, inferior medial genicular artery. Here you can see it again. Perfect. You can see how small the sartorius muscle. This is the first way how to trace the nerve. The other way is, as Dr. Das showed, you can see this is tibia. The left side is cranial, right side is caudal. This is tibia, and when you come close to the tibial shaft, so I'm moving my transducer medially, and now you can see this part here. This is the small artery here showing. This is the inferior, medial inferior genicular artery. You can see on the next slide with color Doppler arm, the same picture. You can see here the inferior, medial inferior genicular artery, and the nerve is right just beside the artery, infrapatellar branch of the saphenous nerve. So this is the second way how to find the nerve. It depends very much how big is your patient and how many operations the patient had before. This is when we do the diagnostic block. This is patella. You can see the nerve there, a needle, and then we inject a small amount of local anesthetic to confirm. First, make the stimulation, and then inject the local anesthetic. Always do stimulation before you try to either do diagnostic block or do the cryoneurolysis. Why we are using the infrapatellar branch of the saphenous nerve? This is because you can see the nerve here, it's coming, and then we can see separate in three different branches. And when they do when the operation is done for total knee replacement, actually they're cutting the nerve because the scar is going like this, and all the traumatic injuries with during the operation. Actually, they're making the damages of the infrapatellar branch of the saphenous. What I always do when I see first the patient, I'm trying to see if there is neuroma. Because if there is neuroma, so I will treat first the neuroma, and then I will go after the nerve. If you ask the patient about the pain, so the patient cannot localize the pain on one spot, they always say that the pain hurts, that the whole knee hurts. I have some video here how do we do the diagnostic block of the infrapatellar branch of the saphenous nerve. Here you can see the nerve, you can see the artery here, you can see the needle. Now we make the stimulation here, and you can see where the ultrasound is. We hold the ultrasound and how to make the diagnostics. Now you can see we are filling up local anesthetics. And the other slides show how we do the cryoneurolysis on the same nerve. And you can see now the cryoneedle is coming. Cryoneedle is not so much visible on the ultrasound. It's not treated for ultrasound, but if you get it in the real implant, so you can see how it works. Now you can see when we are starting cryoneurolysis, a cold will come, and then we cannot see a lot. We can only see actually the upper part of the ice ball, but we cannot see the downstairs because of the acoustic shadow. Now you can see we are approaching with the cryoneedle, which is above the nerve now. And what I will suggest is to do cryoneurolysis above and under the nerve. So in order to get the freezing of the whole circumference of the nerve. Now you can see here, this is the needle tip. Now the cold is coming. You can see the artery here. This is the inferior genicular, medial inferior genicular artery. Now you can see when the cold is coming, the acoustic shadow is coming immediately. So because this is two-dimensional ultrasound, we cannot see around the ice ball. The other nerve which I use for my knee patients is arteriofemoral cutaneal nerve, because I would like to cover the lateral part of the knee, which is very difficult to cover otherwise. And the anterior femoral cutaneal nerve is linked in the subcutaneous tissue. This is the quadriceps tendon. It's a very small nerve. You'll see now a small dot here. This is quadriceps tendon. This is fat tissue here. And then when we make the stimulation, the patient will describe you actually precisely how the nerve is dividing. And you can see here the difference. We are here just below the patella for the infrapatellar branch of the saphenous nerve, and then we are almost 10 centimeters above the patella to find the anterior femoral cutaneal nerve. And this is the very small nerve, very tiny nerve. And this again here, the cryoneurolysis. And again here you will see that when we start the cryo process, so actually everything disappears. It's only black shadow. Here you can see now the formation of the ice ball, and then it's going up. I would like to show you some papers about the knee cryo. I will start with this narrative review, which we did last year when we actually went through almost all publications about cryo. And then we find out that cryo actually is it's safe procedure. We did this acute pain indications and chronic pain indications, but as we all agreed, we need more high quality randomized control trials in order to definitely assess the efficacy of the cryo. I have some double-blinded studies. These were American studies when they did for total knee replacement, and usually they did these studies before the total knee replacement. This one was on 100 patients, and it was they were separated in two groups, and they were measuring the length of hospital stay and the usage of morphine. They could see that the length of hospital stay was much shorter in the group which was cryoneurolysis treated. And then they could see that in the first 12 weeks post-operative, the cryo group used actually zero of opioid comparing to the control group. This is another study. The same, again, it shows that the cryoneurolysis group in the first 12 weeks use less morphine than the control group, and then the COS score, which is very important after total knee replacement, is much higher with the cryoneurolysis patient compared to the control group. This is interesting study because it's this one. It's 180 patients, and they is patients with severe osteoarthritis, and they try to see how the WOMAC score will be 1 year after the treatment. 180 patients, where 120 were received cryoneurolysis, 60 went to shame group, and they could see that actually that 4 months after the treatment, the WOMAC score of the patients was much better. The follow-up, which we made 4 years after, in 21, they could see actually that some of the patients didn't have a need for total knee replacement 4 years after the cryo treatment. This is the one study which confirms that cryoneurolysis. It's a safe procedure for the patients getting total knee replacement, and not opioid treatment is much better than the others. And this is again retrospective study for the cryo in knee patients. Cryoneurolysis as a technique is an effective pain management technique, providing short and long analgesia for the selected patients. It's true that we have scarcity of scientific evidence, and we need more actually. But for many interventional pain management techniques, we have a scarcity of papers. So in this evidence vacuum, we still have responsibility to treat our patients. We cannot just stop and see how we are going to work. We'll have to treat the patients and produce the papers. What is the future? We are talking about using the pre-surgical screening for the patients, find the patients who are at risk, offer them cryoneurolysis before the surgery, and find the others if we miss some. So after the surgery, we have to see how the acute and chronic pain will go. If the patients have pain after 3 months, so we'll have to offer them cryoneurolysis from the standard care. So this is what we are working now a lot to implement cryo in the acute pain settlement. What are the tips for success for cryoneurolysis? Always perform a diagnostic block, and the diagnostic block should perform with neurostimulation and with small amount of local anesthesia, 0.5 to maximum to 1 milliliter of lidocaine. Otherwise, you will actually get false positive results if you anesthetize all the nerves in the area. Expectations for the patients, local anesthesia works always 100%. We have to tell the patient that the cryo will be 70% as good as the local anesthesia, and use large lesions. I sometimes actually add some local anesthesia or saline around the nerve to provoke a bigger lesion of freezing with cryo. In 2022, I founded the International Society for Ultrasound Guided Cryoneurolysis. This is the board of the society. We are our goal is to advance the frontiers and knowledge about the ultrasound guided cryoneurolysis. We are now creating a platform where we can exchange the knowledge, opinion, experience. We try to establish the international guidelines, which we are working now on a lot of. It's very difficult to pronounce it or promote it like a guidelines. It's more like a recommendations, because the guidelines need some more studies to be done. We are preparing our third annual conference. This year will be in Vienna, in Austria. We had a 2 year, 23-24 in Copenhagen, but this year we are moving the conference to the Vienna, and this conference will be actually with CME accreditation. We have pending approval now, and we are hoping that in next 2 weeks the conference, the program will get CME credits for. These are the links for registration on the website, and these are the website for the society, so where you can become member and you can apply for membership and for the registration for the conference. And these are my contact information. This was all. Now I will leave the word to the others, so we can start the question and answers session.
Okay, there are certain questions in the chat box. So I'll be asking the GE team to throw this question. And so one last question, what I saw is whether it is effective in the cancer pain management. Definitely it is yes. So we can I myself has done several cases, but that depends on the type and whether you can look at the nerves. Dr. Igor, if you can clarify it more.
How many sessions
cancer pain management? What is the role? That is the question.
Cancer, okay. Yes, we use cryo in cancer pain. Actually, it's very depending where on the body is the cancer and where the pain is. It's very difficult to treat deep abdominal cancer pain, but we are treating actually the patients with pancreas cancer on celiac plexus with cryo, and we do a lot of patients with abdominal or bladder pain with ilioinguinal hypogastric and general branch of genitofemoral nerve. We treat patients with cancer pain with osteomyelitis or bone cancers, if we can get the nerves which we can target it actually.
In fact,
Any safe distance from the
have some
skin.
experience. I have Dr. Igor. I also did
Yeah.
some cases in the ribs metastasis, chest wall pain and abdominal wall pain. These are
Yes.
metastasis. So here the role of cryo is excellent.
Yeah. Melanoma, malignant melanoma, if you have it on the inguinal region or on the chest, we are treating a lot of patients actually with cryo. Is the safe distance from the skin to avoid necrosis? No, you cannot do necrosis on the skin because we have some studies where we did actually on the rats, and you cannot freeze the surrounding structures around the nerve because there is temperature difference. The cryo needle is not so cold. If we use argon gas, so you can provoke freezing, but not with the nitrous and CO2. How long the patient is pain-free with cryo treatment post-TCare? It depending. If we are doing the procedure approximately 9 to 12 months, this is where we see the knee patients. But if you do it preoperatively, some of the patients you can get up to 2 years afterwards. How many sessions do you have to plan for the knee pain? 2 sessions. One session is when you're doing examine the patients and when you're doing diagnostic blocks, and the second is when you invite the patients to do the cryoneurolysis. So usually one session is enough when you do the both nerves.
So good evening, sir. I have a question, sir. Sir,
Yes.
this is regarding celiac plexus cryoneurolysis in cancer pain. So,
Yeah.
sir, can you please elaborate this? I want to know more about it, sir. Thank you, sir.
Yes, we perform the procedure actually for the terminal cancer pain patients. It's not for the patients who are getting the cancer but don't have pain. Usually in Denmark, we do it for the patients who are terminal. And then we do it percutaneously. We sit the patient, then we are coming on the back side on TH12 of the both sides of the columna, and then we are freezing the celiac plexus. It's very important to avoid the aorta because you have the bone, then you have aorta, and then the celiac plexus is just on the both sides of that. And then we are starting from one side to another side. This is how we perform the procedure here, but it's very important that the patient should be in the hospital setting, not in the ambulatory setting, because we experience a lot of patients are becoming hypotensive and they're getting some diarrhea afterwards. So it's very important that the patient is in the hospital. I hope this will celiac will make pain-free if metastasis is there. It's I don't know. We try a lot, but you know the patients I see are typically with metastasis all over and they have pain all over. So if it will helps only for the metastatic, I don't know. I cannot explain you that. One session is enough. Usually the knee is very complex joint. There is a lot of nerves coming up and down. So sometimes if, for example, infrapatellar branch of the saphenous nerve and anterior femoral cutanous nerve are not enough, so you can call the patient and then you can do the vastus medialis, vastus lateralis. You can do the medial femoral cutaneous nerve, not only the anterior. So this is where how we treat the patient. But I always start with infrapatellar branch of the saphenous nerve and anterior femoral cutaneous nerve. If it's not enough, so I will call the patient again. I will try to find some other nerves.
Dr. Igor, so I am sure that this question is also from not only for me, for the others as well. So you no longer call it as a superior genicular nerve, superolateral genicular nerve, inferior genicular nerve. This was the conventional way to call it.
Yes, this is conventional way to call it because this is the pronunciation from the pain doctors using radio frequency.
Right.
What is the difference? The difference is when you are pronouncing like inferior medial genicular nerve. If you're inferior, we can see, but for example, if you take the superior lateral genicular nerve, you can only see the artery, you cannot see the nerve.
Right.
And what is the problem? If you don't see the nerve with cryo, if you don't freeze, if you don't put your needle on the nerve, so you cannot freeze the nerve. So you won't achieve the good results. When you're doing radio frequency, so then you don't have to be on the nerve. You can be somewhere around the nerve, hit the whole area, and then you will achieve the result. So that's why I always say, if you're doing cryo, you have to pronounce the correct nerves and find the correct nerves.
But on the lateral side, you have shown the anterior cutaneous nerve, right?
Anterior femoral cutaneous nerve, I find it actually on the front.
So on the lateral side, somebody who's having the lateral knee pain. So which nerve are you going to target?
I will take vastus lateralis there.
Okay.
Yes, I will take nerve to vastus lateralis. I will trace it actually, so you can trace it maybe up to 5 centimeters above the knee, and then you can get it on the lateral part. It's lying just
and another thing is what you have shown as the inferior interpatellar branch of the saphenous nerve. It's close to the inferior medial genicular artery. So
yes.
then so normally it is the same target for the inferior medial genicular nerve. Means the inferior medial genicular artery accompanies the nerve. This is the conventional way to think and treat it with the radio frequency. So
yes,
you feel it is the same nerve which is intermediate genicular nerve and inferior interpatellar branch of the saphenous nerve are the same nerve, or they are the two different?
Is the same nerve. And there is also a very nice pathological study from Philip Penck where he describes the innervation of the knee, and you can see actually that it's the same nerve.
Okay.
Yeah.
Actually, what you have shown in the video, that tracing the interpatellar branch of the genicular nerve in the adductor canal, we can trace it up to certain part. After that part, it becomes almost invisible. Means it is very difficult to trace, lateral to the medial to the medial meniscus. So
yes, but you don't. I don't trace the nerve.
Yes.
I trace the muscle. I trace sartorius muscle, because when you trace sartorius muscle, it starts like this, and then it became smaller and smaller and smaller.
Smaller and tendinous.
Yes, and then you can see the infrapatellar branch of the saphenous nerve jumping from there. Okay. So this is why I always trace the muscle first in the first place.
Okay. So any other question for Dr. Igor, or any other question on the ligaments as well? You can just unmute yourself and you can ask us directly. You can raise your hand. No more questions?
Shweta, can we unmute participants?
Yeah.
Yeah.
Okay, anybody else have any questions? They can directly ask it instead of writing it on the chat box.
Yeah, now platform is open for all now. Oh, they can unmute and ask question if anyone has.
Yeah, good evening, sir. Nerves which can be used for the cryoablation can be used for, say, cool radio frequency ablation for knee pain.
Yes, You can also use cool radiofrequency. Actually, on the conference which we are preparing now for May, we're going to have a session where we compare cool RF with cryo for different procedures, including the knee pain.
So this is about celiac plexus cryo. So is it possible to create a big enough lesion to cover the whole of celiac plexus with cryo?
If it's can you repeat the question?
Yeah. So is it possible?
He's asking the cryoneurolysis, can it create a big enough lesion? Because celiac plexus is a very big ganglion.
Yes.
So can we,
Yes, but
enough part can be neuralized? That is what his
yes,
question.
we have several types of needles, several thickness of the needles, and when we are doing for celiac plexus, so we are using 2 millimeter probe for cryo, which is very powerful. So you get almost 2 centimeters of the ice ball. So if we are treating the knee pain, so we are using from 0.9 up to 1.3 millimeters. So it's huge difference in between the diameter of the needles. So 2 millimeter needle is for celiac plexus.
One more doubt. How we have to choose whether to go for the cryoablation or the cool radiofrequency ablation for the patient having the knee pain? Like any eligibility criteria for the patient to take?
No, it's the same. I used to always, if you are treating the patient with the warm or the cold, it's the same for the patient. How we choose the patient is more what is my preference. At my clinic, the only treatment I offer is cryo. If you can get results from cryo, it's cryo. Otherwise, I won't offer you radiofrequency or something else. So this is the preference of the doctor.
You might be aware that the last time I was talking, in fact, we are conducting a study where we are basically comparing these two in terms of the efficacy and in terms of the longevity of the pain relief. So we are comparing the cool radiofrequency versus the cryoneurolysis. And we are using the different probes. So Metram has recently come out with a special probe for the osteoarthritis knee. It's a little bit of bent tip and little bit of
bent and very thick,
and
yes,
which can cause a very big lesion, theoretically bigger than the cool radiofrequency also. So it might be more effective even if you are unable to see the nerve. Like in the conventionally, in the radiofrequency, what we do, we are not always seeing the nerves. Most of the times we are not seeing the nerves. We are either putting our probe in reference to the bone or in reference to the genicular arteries. In that way, we can put the probes, cryoprobes as well. In fact, in our study, we are putting the cryoprobes larger, bigger, the cryoprobe in the same way, same targets for the cool radiofrequency probe, and we are comparing the efficacy as well as the duration of the pain relief. We are comparing with that.
Okay, sir. Thank you, sir.
But this kind of study, comparing both the different kinds, cool versus cryo, this kind of study is not available right now.
No, but it's very important what type of patients you are seeing, because if you see the patient which you have
that is always true. What kind of patients exactly the pain generators?
Yeah. There's one question here. Nerve for cryoneurolysis is sensory and motor components. Is safe to use? Yes, we do many patients with suprascapular nerve, which is 80% motor nerve and 20% sensory nerve. But anyway, we are doing the cryo because when we take the infraspinatus and supraspinatus muscle out of function, the deltoid muscle will overtake the function, and then there is no. We are not afraid that you cannot see actually the atrophy of the nerves because of the passive movement, and then we use a lot of motor nerves when we treat spasticity patients. So we are using we are freezing the motor branches in the muscle. So no worries, you can do everything.
Okay, sir. Thank you, sir.
Okay, somebody was asking, can I use the cryo for the splanchnic nerve? Why not? Dr. Igor, what is your answer?
Yes. Why not? You can use it everywhere, actually. Yeah.
And another question is side effects of allodynia and dysesthesia. So that is the advantage of the cryo, that allodynia and dysesthesia do not persist because it is causing the second degree nerve lesion. The radiofrequency causes the third degree nerve lesion. So where this dysesthesia, allodynia can persist for the longer time, because we are creating third degree lesion and the neuroma formations, then the crosstalk, ectopic signals, all this is possible for the radio frequency, but not for that. This is the reason why the automatic choice for the peripheral nerve, where important sensory fibers are there, like the occipital, like the lateral femoral cutaneous, genitofemoral, ilioinguinal, all these nerves, radio frequency is not a choice because their allodynia will be persisting. But here it is the choice, cryo is the choice because here the allodynia and dysesthesias are temporary. It's short-lived.
Yeah, but also if the patient gets allodynia or dysesthesia, usually they get after 5 days. And then I will call the patients like acute in the clinic, and then I will do shutdown block with some long-lasting local anesthetics. And usually it helps actually. 90% of the patient, the pain doesn't come back. So if the pain comes back, so I will repeat shutdown block again after several days, and then I will repeat cryo again, because if the pain comes back, it means that I didn't froze the nerve enough. So this is where you have to be aware. We are very depending from the technology we are using, and that's why I always say we don't know how cold the needle tip is. This is very important because the ropes we are using, they don't have thermocouples on the nerves or the probe. So that's why we don't know what the real temperature is.
Okay, one question
Yes,
is, can it be
yeah,
used in the
trigeminal
trigeminal neuralgia?
neuralgia.
Yes,
Yes.
no, let me share my experience, then Dr. Igor, you can say also. We used
Yeah,
in 2 cases, 3 or 4 cases, but the most important disadvantage of the trigeminal neuralgia radio frequency versus the cryo, the radio frequency gives the longer lasting pain relief. Whereas the cryo, my experience was less than 1 year, mostly the 6 months pain relief. So this is one of the disadvantages that we are doing a bigger procedures, invasive procedures, and patient expects long-term pain relief. Which is my, few cases. Dr. Igor, you can tell your views.
yes. Actually, I don't promote cryo for trigeminal neuralgia. I say always that here's the radio frequencies. It's much better than cryo because you can do radio frequency on the ganglion. You cannot do cryo on the ganglion because the lesion will be, it's impossible to do it. What we use cryo is on the peripheral. So it will see if there is no neurovascular conflict on the trigeminal ganglion. So you can do cryo on V2 or on infraorbital mental nerve. We can do supraorbital, the infraorbital, supraorbital nerves. But I don't promote cryo for trigeminal ganglion because you cannot put 1.3 millimeter probe inside and freeze the ganglion. This will provoke actually a huge pain to the patient. So that's why I always say, if there is no neurovascular, because 2 years ago, the Neurosurgical Society from United Kingdom, they came with some statistics that 86% of all patients with trigeminal neuralgia have neurovascular conflict. What does it mean? Neurovascular conflict means that the trigeminal ganglion is suffocated from the basilar artery into the brain, into the brainstem. So that's why we always say first that we do the MRI scanning of the trigeminal ganglion, and if there is no neurovascular conflict, then we can treat the patients peripherally, or I send the patients for radiofrequency in the ganglion.
Okay, another
So
thing,
this is where,
Dr. Igor, I want to mention that the 22 gauge needles are also, cryoprobes are also available. I prefer, I have done 2 cases that where the radio frequency ablation was done and repeated 2-3 times was already done. So if somebody is having the recurrence after the 2-3 times of the radio frequency procedure, so they are further doing the neuroma and all those, the paresthesia, what we call as a anesthesia dolorosa. Anesthesia dolorosa is a bad complication of repeated radio frequency procedure. So in those situations, cryo can be a better choice because cryo never causes this kind of anesthesia dolorosa.
no, neuritis, sorry, yeah. This
Neuritis
is true.
is not a possibility
Not
because
neuroma
of
formation, yeah.
right.
Yeah.
And so this is the one very important indication where we can use the very thin probes and we can do it.
Yeah, that's true. There are some other questions, or?
Medial compartment ligaments to list, sir. Medial compartment, again, my volunteer is not ready right now, cameras. So medially, I told you the medially most superficial ligament is the continuation of the vastus medialis, that is your medial patellar reticulum. Below that, closer to the patella, is your patellofemoral ligament. And if you are tracing that patellofemoral ligament more medially, it intermingles with the superficial band of the medial collateral ligament. And below that, another layer of the ligament, that is the deeper layer of the medial collateral ligament, that is known as the two part of it. One is your meniscofemoral, another is your meniscotibial ligament. So in fact, on the medial side, just above the meniscus, we are having the three layers. And if we are going little bit more anteriorly towards the closer towards the patella, we'll be getting the two layers. Okay, it feels that no more questions, Gita?
Yeah.
Or anybody in the team?
Yeah. Am I audible?
Yes, yes.
Yes.
Yeah. So I would like.
Okay,
thank
so can we end this session if no more questions?
I think we have done. It's almost 7:45 India time. And we were as per the plan. And I would like to thank Dr. Das and Dr. Igor for the great insights. And participant, I just would like to inform that we will be coming with the next series 4 and will share. And post this, the recording will be also shared by everyone. So thank you. Thank you, Dr. Igor. And thank you, Dr. Gautam and Shweta team for the tech support. Great
Okay,
learning.
so thank you, GE team, and thank you, Dr. Igor, for joining.
Thank you, G. Thank you,
And very
Dr.
nice
Das. Yes.
interactive
Thank you.
discussions, newer insights. I am sure that all the participants are benefited.
Correct.
I hope so.
Okay.
Thank you.
Have a nice evening. Thank you.
Have a great
Bye.
time. Thank you. Thank you, everyone. Bye.